So now let's go coming to GIT physiology. We'll talk about physiology part GIT from Ivmrcs. What about stomach cells and secretion? Content of the stomach is always acidic, around 1 to 3 pH. Types of secretion: hydrochloric acid is maximum secreted, intrinsic factor calcium, sodium, magnesium. These are the ions secreted. What are the different cells? These are parietal cells, also called as axanthic cells. There are gastrine cells, chief cells, mucus cells. Just important point is which cells are secreting hydrochloric acid, which cells are secreting pepsin, pepsinogen, Pepsi Cola. The word Pepsi Cola, Pepsi chief for cola, P is pepsin. They are secreting pepsinogen. So this is activated by hydrochloric acid and cod. And parietal cells, also called as axanthic cells, they increase hydrochloric acid through histamine, muscarinic receptors by vagal stimulation. Whenever vagal stimulated, there are muscarinic receptors or M3 receptors or the gastrine. These all three cause increased hydrochloric acid secretion. And what is opposing it? Prostaglandin E2. So proton pump inhibitors we give, they are prostaglandin inhibitors. They decrease acid secretion. The gastrine cells, these are by the parietal cells. Gastrine cells are present in gastric antrum and pancreas, stimulate hydrochloric secretion by parietal cells. Gastrine cells are stimulating the parietal cells to secrete hydrochloric acid, has tropic effect on parietal cells. It acts directly via increased histamine, stimulate gastric emptying. This is a stimulating gastric emptying and intestinal hormones. Inhibits intestinal hormones, inhibits gastric emptying. Gastrin stimulates emptying. Parietal cells or chief cells secrete pepsinogen. Again, it is activated by hydrochloric acid and peptidase. Mucus cells secretes mucus and bicarbonates to prevent autorization and neutralize the acidity. Damage to parietal cells. These are the parietal cells. If they are damaged, that may lead to pernicious anemia. And there is intrinsic factor deficiency. So vitamin B12 deficiency is there. Deficiency of vitamin B12 will cause deficiency of intrinsic factor, lead to pernicious anemia, lead to, this is the reason of deficiency of leading to pernicious anemia. What is gastrinoma? Gastrin cells are present, recurrent peptic ulcer that causes increased hydrochloric acid secretion, leads to diarrhea and steatorrhea because of decrease in lipase. It is a part of MBN1. H. pylori is a gram-negative organism, increase acid production, produces urease and form the basis of CLO broad test, amoxicillin, clathromycin, metronidazole. Here you can see the secretion of into the lumen. This is the wall cells in the stomach, acetylcholine. These are receptors, muscarinic effectors. Calcium is released. Histamine causes ATP to forms AMP. Gastrine, through the calcium. Potassium ATPase. This is the luminal membrane. Potassium is withdrawn in. Hydrogen is going on. HCl. So hydrochloric acid is secreted into the lumen by the action of vagus, histamine, gastrine. This is through muscarinic effect. This is through the histamine receptor. This is the gastrine. G receptors. 3 to calcium is required here. Cyclic ATP is converted to AMP. And this one is causing so proton pump inhibitors acts on hydrogen HK ATPase inhibition. This is the HK, hydrogen and potassium. This is the pump. This acts here to decrease acid production. Activated acid media used in peptic ulcer treatment. Ghrelin hormone is secreted from the fundus of the stomach and responsible to hunger in blood to stimulate hypothalamus feeding center, causing hunger and obesity. While leptin secreted from adipose tissue. Leptin is secreted from adipose tissue, and that causes satiety. And ghrelin is for increase in hunger. Adipose tissue has got ghrelin, leptin, adipose, ghrelin in the fundus. Gastric emptying metachlorpromide. It depends on the vagus. While if vagotomy is already done, erythromycin is acting as a for gastric. If gastrectomy is done, you get deficiency of vitamin B12, lack of intrinsic factor that punishes anemia, iron deficiency. It is a wrong ionic state for absorption. Dumping syndrome early is 30 to 35 hyperosmolar food, third space loss due to dehydration, and late release of insulin. Hypoglycemia. A person gets symptoms of hypoglycemia. Now coming to pancreatic exocrine secretion. Pancreas has got exocrine and endocrine. Exocrine secretions, endocrine will be seen in the hormones. This is through the duct and acini. So bicarbonates plus water, they form sodium, potassium, chloride, neutralize the acidic chyme. And what are enzymatic secretion from the pancreas? Trypsinogen, lipase, amylase, elastase. Trypsinogen activated by enterokinase and first active to digest protein. Trypsinogen is for the protein responsible for autodigestion. Whenever there is autodigestion and necrosis and then necrotisis, it is because of trypsinogen. Lipase helps digest the fats and deficiency response for sticking the commode and cannot be because because lipase deficient more fats are excreted in the stools, and the stools are unable to flush out from this. And amylase is helping for digestion of the carbohydrates. Elastase in chronic pancreatitis, first non-invasive test is fecal elastase. So this is the question. Fecal elastase is tested as a non-invasive. Lipase is the enzyme which is responsible for stool sticking. Trypsinogen is responsible for autodigestion of the pancreas. So next is small intestine. This has got alkaline pH. The hormone it's secreting is cholecystokinin, secretin, somatostatin. Pancreatic acinar cells form enzymatic action, contracts gallbladder to release cholecystokinin. Cholecystokinin causing gallbladder to gall's bile contraction, and secretin pancreas ducts alkaline secretion from the hepatic core. Somatostatin that decreases pancreas secretion, decreases stomach secretion. Small intestine mucosa, main function of small intestine absorption of the large surface of the absorption villi with microvilli, water. It has crypts of lubricant and contain Paneth cells, which is important for immunity. Duodenum contains Brunner cells. Circular muscles and longitudinal inner are circular, outer longitudinal. Peristalsis there, decreased by sympathetic and increased by parasympathetic peristalsis. What are the bile components? Bile pigments and bile salts, waste product from the breakdown of the hemoglobin by the RBC. The bile pigments formation, excretion, bilirubin from RBC, albumin is separated, hemobilirubin indirect unconjugated in liver, bilirubin is conjugated 25 glucuronic acid to in large intestine, glucobilirubin is reduced to stercobilogene. Function is helps in fat digestion, help fat vitamins absorbed from the body with the help of fate of the bile pigment 25% returned back to the liver by intrahepatic circulation, 70% stercobilogene excreted in the stools. Fate of bile cells 90% returned back and rest of the excreted in the stools. The jaundice is again of three types. Pre-hepatic before liver, it is hepatic because of liver. Post-hepatic is obstructive. If there is excessive hemolysis, there will be indirect hemoglobin will be raised. If there is hepatic cause, there may be biphasic hepatic, and when there is obstructive cause, there is increased direct that is conjugated bilirubin. And signs of alkaline phosphatase will increase. LDH is will also increase in pre-hepatic type. So you can see extravascular, intravascular hemolysis, blood, unconjugated urobilin goes into kidneys, urobilin, unconjugated conjugated bilirubin is excreted in the kidneys. What are these MRCS scenarios? What are the questions? Causes of dark urine obstructive jaundice: increased conjugated bilirubin in the blood. Itching is because of bile salts in the blood. Pale and offensive stools because of decreased intrahepatic circulation. Post-cholecystomy, decreased intrahepatic circulation. Multiple stones, dark unconjugated bilirubin is present. 14 days jaundice, the biliary atresia is the cause. Effect of terminal iron resection: decreased bile cell absorption, so decreased fat soluble vitamins. Oral cholesterol has to be given. Vitamin 2 causes macrocytic anemia. Vitamin B12 absorption gives to macrocytic anemia. Hypoglycemia, vitamin this is absorbed in the terminal ileum. Hypocalcemia due to binding of the calcium. What is the mechanism of lactulose? It acts in the colon, reabsorbed in the colon. Site of action is basically colon. Lactulose with normal bacteria produces lactic acid. What are the different vitamin deficiencies which cause different signs and symptoms? Vitamin E is related with the eyes, blindness. B1 is alcoholic patients with a neuropathy called as Wernicke's neuropathy. Triad is confusion, cerebral ataxia, ophthalmoplegia. B2 is riboflavin, angular cheilitis, dermatitis. B3 causes pellagra, pernicious anemia. This is pellagra B3, and B12 causes pernicious anemia, neuro and ataxia, psychological mood disturbances. It has to be given. Treatment is given is vitamin B12 intramuscular, so folic acid. Vitamin B12 has to be given with folic acid. Pregnant patient, folic acid is given. Vitamin C is required for wound healing. Vitamin D causes rickets in children and osteomalacia in adults. Vitamin K causes clotting deficiencies.